Is that working?
Yeah. So we are starting today's session. Am I audible properly?
Sorry, I didn't. I'm ready to go whenever you are.
All right, we're starting. I said we're starting, Dr. Atif.
Okay, sure.
I just want to give a brief introduction, then you can start your presentation. So my name is Dr. Sehrish Abrar, and I'm going to facilitate today's session. I welcome you all in today's CME, and a special thanks to Dr. Atif Jalees Khan, who take time for us from his busy schedule. I just want to give a brief introduction of Dr. Khan. Dr. Khan is a leading radiation oncologist working in Memorial Sloan Kettering Cancer Center since 2017. And Dr. Khan is an AQU grad. He completed his residency at Rush University Medical Center, and his site-specific interests are breast, CNS, and pediatric tumors. Dr. Khan has authored and co-authored several papers and I would say several practice-changing papers, and one of the paper is NSABP-B51 trial. So the purpose of today's meeting is to discuss the results of NSABP-B51 trial, particularly its finding regarding the potential omission of radiation therapy in select group of the patient after complete nodal response, and to understand that how these results would implement the clinical practice. So over to you, Dr. Khan.
Okay, great. Thank you, Dr. Sehrish, for the introduction. It's an honor to be here with all of you today, and I will try to keep my talk to about 45 minutes or so we can leave some time at the end. Hopefully, we can make that work. So I'll be speaking about RNI and regional nodal irradiation and PMRT, particularly in the neoadjuvant, post-neoadjuvant context. But I'll try to also spend some time on the RT charm hypofractionation trial, which I think will also be practice changing. So I often give this talk where I go through some of the seminal data that has informed our practice with respect to post-operative treatment of breast cancer, and really going all the way back to Halstead's first paper in 1894, where he showed that with mastectomy you can actually cure some breast cancer patients. Before that, it was felt to be incurable. From there, the next thing that happened was noticing that the majority of failures after mastectomy were happening on the chest wall, and also some in the lymph node, but predominantly on the chest wall. And from there, people began to add radiation. And as you start to fast forward, all of these are papers that most of you are probably familiar with, and we can, at some point, these are actually all clickable hyperlinks, and we can go to each of these reports and look at what they showed. But we're actually going to focus on the bottom part of this timeline. Up here is the upfront surgery setting, either breast conservation or mastectomy, but kind of in the intermediate risk with nodal involvement. These are the kind of seminal papers. And then here is the neoadjuvant. So the neoadjuvant paradigm creates a different set of problems or questions for us as radiation oncologists. And these are some of the key data. And we will look at some of these actually. So let's get started. And then, yeah, so these are the two ongoing studies that will help us understand the best local regional treatment after neoadjuvant chemo. We'll be talking about the B51 because that's been fully reported now. So we'll talk about local regional treatment after neoadjuvant chemo. We'll talk about hypofractionation for PMRT, and then if we have some time, one thing that's really important is just techniques, like how should we do this treatment? Try to talk a little bit about that. So in neoadjuvant treatment, the key sort of conceptual framework has been that should the scope and the intensity of the local regional treatment correspond to the risk profile of the pre-treatment clinical pathological picture, or should the tumor's treatment responsiveness be the main determinant of the treatment approach after the neoadjuvant chemo? Like, which one actually matters? Is it the upfront clinical risk profile, or is it the post neoadjuvant risk profile that should count? And that's something that we didn't really understand. Now, before B51, there was a host of retrospective data that tried to look at this question. Many of these were institutional series. Many of them were actually done at MD Anderson Cancer Center. I'm just going to show you one of these from MD Anderson, in which they sort of took the best possible patients. They took patients about 100 patients who had a complete pathological response to preoperative chemotherapy. And then they looked at, this was not randomized, they just looked at, some of them got radiation, post-mastectomy radiation, some of them didn't. And then they looked at the results as a correlate of whether they got the post-mastectomy radiation. And with a median follow-up of about 60 months, the local regional recurrence rate was much higher without radiation, about 30%, than those who had radiation, especially if they had clinical stage 3 disease at baseline, which was about 70 patients. And this post-mastectomy radiation actually also improved distant metastasis-free survival and overall survival in the stage 3 patients, just like we see in the post-mastectomy trials, the Danish trials and the British Columbia trial. So this seemed to suggest that no matter what we saw with respect to the response, if the original disease was high risk, let's say, you still needed the post-mastectomy radiation. I'm just showing you one of these reports in the interest of time, but there were many reports that seemed to suggest that the initial clinical extent of disease had to be considered. You couldn't ignore the initial clinical disease, and it seemed to actually override, even if there was a very good observed response, it didn't seem to matter. The high risk of local regional recurrence seemed to still be there. Now, another data set that was also available and was used is this data from a pooled analysis of 2 prospective studies. So this is a retrospective analysis of 2 prospective studies, the B18 and B27 studies that were done from the NSABP. These are actually chemotherapy, neoadjuvant chemotherapy regimen trials that have nothing to do with radiation. But what they did was they were able to go back and look at the risk of local regional recurrence in this cohort of patients who were treated with neoadjuvant chemo. And one thing that's really important to remember in this data, in the protocols of these studies, they were not allowed to give regional nodal radiation to the lumpectomy patients. It had to be breast only. And for the mastectomy patients, they were not allowed to give them post-mastectomy radiation. So it's a good observational data set to understand what the risk of recurrence is without RNI and without PMRT. And what they found was that when you look at patients who are initially clinically node positive, if they remain clinically node positive, both in the breast conservation and in the mastectomy setting, they have a pretty high risk of local regional recurrence, about 20%, let's say, depending on which cohort you look at. But if they're initially clinically node positive and then they become clinically node negative, which is this intermediate column here, their risk of local regional recurrence is about 10 to 15%, so sort of intermediate type of recurrence risk. If they have a pathological complete response in both the breast and the nodes, their risk, local regional risk recurrence is very low, really around 5%, 5 to 8%. So this, and when they look at sort of, did a multivariate model to understand which of these factors were predictive of local regional recurrence, age, in the breast conservation cohort, age, clinical nodal status, and whether they had, like what kind of response they had in the breast and in the nodes. And similarly, in the mastectomy setting, the size of the original tumor, clinical nodal status, and the response, all of these were independent predictors of local regional recurrence. Now, one thing that I also want, I always show this study, this was a patterns of care study done retrospectively on patients who were enrolled on the ACOSOG 1071 study. This was a cooperative group study that doesn't have anything to do with radiation. It was a study to look at the accuracy of sentinel node biopsy after neoadjuvant chemo. The radiation and the surgical approach was completely up to the surgeon and the radiation oncologist. There was no protocol guidance on how to do that. But it was still interesting to see how do people actually treat in this situation. So in this study, everyone had to have a biopsy-proven positive node. Everyone had to have neoadjuvant chemo. Everyone had a sentinel node biopsy, and then they immediately had a lymph node dissection. And the idea was to see how accurate the sentinel node was. That's not what I'm going to talk about today. What I want to show you, though, is in the patients who became node negative, right? So they're node positive to begin with, and then they became node negative after neoadjuvant chemo. There were 284 patients. About half of them had breast conservation. The rest had mastectomy. When you look at the breast conservation cohort, and you look at whether they had regional nodal radiation or not, it was almost 50-50, right? So in this group of women who are clinically node positive and become pathologically node negative after neoadjuvant chemo, the doctors really didn't know what to do. Half of them were giving nodal radiation, the other half were not. And similarly, on the mastectomy side, if there was mastectomy without reconstruction, the use of PMRT was 80% to 20% not getting it. But if there was a reconstruction, it's about 70% versus 30%. Again, this is because probably the doctors are concerned about the effects of the radiation on the reconstruction. But these numbers just go to show that we had clinical equipoise, meaning we didn't really know what to do in this group of patients. And remember, we had the MA20 study, which looked at whether RNI improves outcomes in the upfront setting in a breast conservation cohort and seemed to improve these endpoints. And similarly, the EORTC 22922 study also showed an improvement with regional nodal radiation. This is in the upfront setting. But the question is, okay, could we potentially have the same demonstration of a 3% improvement in, let's say, any recurrence, or let's say distant metastasis-free survival, with the use of regional nodal radiation in the post-neoadjuvant setting? And so that's what the B51 study was trying to do. Now, before we look at the actual data, two important points to remember. Number one, it's okay to look for nuance in clinical trial data. It's complicated. Like there can be, different types of insights or different types of nuances that can affect the results of the data. So, and this is exactly why, we don't generally treat all upfront patients who are, have 1 to 3 positive nodes with regional nodal radiation PMRT. We need to take a more, subtle sort of approach.
Dr. Khan, you are mute.
Somehow, okay, not sure how that happened. So, for example, at MSK, this is the nomogram, not the nomogram, but the risk table that we use to decide who should get regional nodal radiation or PMRT. And, there's primary risk factors, secondary risk factors, and then we use combinations of these risk factors to decide if regional nodal radiation or PMRT is necessary. The other thing I want to point out is that follow-up is important, and sometimes the results can change with additional follow-up. Certain things can become unmasked with additional follow-up. For example, this is the EBC-TCG meta-analysis of regional nodal irradiation trials, and you really had to get out to 10 years to see this difference in breast cancer-specific mortality with the use of RNI. It's a small benefit, but it's still a benefit. But really, you have to wait, until 10 years out to actually see this benefit. So, okay, so now So now two more points before we look at B51. Sometimes you can have a situation where someone has a clinically positive node that becomes pathologically negative, but they may still have a lot of disease in the breast. And we know from many studies that having RCB2 or 3 disease is bad, both for distant recurrence and also for local recurrence. I'm showing you here a secondary analysis of the Keynote 522 trial of neoadjuvant chemoimmunotherapy for triple negative breast cancer. But how well the tumor responds can of course be important, and you can still have a complete response in the nodes, but not in the breast. So that's an important thing to remember. Now, coming to the B51 study. So I was, as Dr. Sehrish said, I was involved with this study. I was one of the radiation oncology co-PIs. And in this study, you had to be clinical T1 to 3, clinical N1 with a biopsy-proven node that was positive under the arm. And then everyone got neoadjuvant chemotherapy. Everyone had to have a pathologically negative node in the axilla at the time of surgery. And then they were randomized to either get regional nodal radiation or no regional nodal radiation. So if they were breast conservation, then they only got whole breast radiation if they were on this arm. And if they were on the experimental arm, then they got breast and nodal radiation. And if they had a mastectomy and they were on this side, they had no post-mastectomy radiation. And if they were on this side, they had post-mastectomy radiation. There were also some predefined stratifiers, such as the type of surgery, mastectomy versus lumpectomy, hormone receptor status, HER2 status, the use of postoperative chemotherapy, and whether or not they had a path CR in the breast. All of these were predefined stratifiers in the study. Now, one question that I think many people don't quite understand is, what is the control arm in this study? The control arm in this study is to actually not treat the regional nodes. So remember how I told you in that NSABP-B18 B18B24 study, they did not allow for regional node radiation, even if the nodes were positive, and they did not allow for post-mastectomy radiation. So the control arm here, the historic standard was to not treat, and this was a superiority study to see if the addition of regional nodal radiation could improve the primary endpoint of invasive breast cancer recurrence-free interval. And this is actually how MA20 was designed to, is also a superiority study. So in a way, this is like MA20, but now done after neoadjuvant chemo. And this was the background. These were the statistics, 14% looking for an improvement to 35% with regional nodal radiation. Okay, so again, primary endpoint is invasive breast cancer recurrence-free. So any type of breast cancer recurrence. Secondary objectives, local regional recurrence, distant recurrence, disease-free survival, overall survival, and also toxicity. We already went through this, and we went through this. So about 1,600 patients were enrolled, about 800 in each arm. And the median follow-up here is 60 months. These are the patient characteristics. The arms were pretty well balanced. One thing that I do want to highlight is that 80% of patients on this study, not only did they have a complete response in the nodes, which was required in the study, 80% also had a complete pathological response in the breast. Okay, now why is this happening? Probably because the treating doctors, maybe they were worried. They wanted to they were being conservative. They wanted to put a low risk type of patient on the study. So 80% had a total path CR. And when you look at the receptor subtypes here, about 50% of these patients, actually 55% of them, were HER2 positive. So there's an overrepresentation of HER2 positive breast cancer, even a slight overrepresentation of triple negative breast cancer, 20%. So 85% of these, there's only 20% were hormone receptor positive, HER2 negative. So we'll come back to that in a little bit. Also about 50-50 split between lumpectomy and mastectomy. Now here's the top level result for invasive breast cancer recurrence-free interval. These curves are totally overlapping. There's no demonstrable improvement with the use of regional nodal radiation. Really no improvement in very low local regional events in the study, as you can see here. And these are not statistically significant, also really not clinically meaningful. Here's the breakdown of local regional events. Same thing with distant recurrence-free interval, disease-free survival, and overall survival, absolutely no difference. Now, when you look at the forest plots for the different subgroups, here is the stratifiers that I told you about, right? These were the predefined strata. And as you can see, there's really no improvement in any of these. They're all intersecting here. But you can see some of them are, quite a few of them are trending here towards benefit with RNI. So for example, being ER positive, you see a slight shift in this favoring RNI, and the hazard ratio is 0.66. Obviously, the p-value is not significant, but this is kind of interesting. Similarly, if you did not have a path CR in the breast, okay, so no path CR, you can see here it's also trending in this direction with a hazard ratio of 0.74 favoring RNI. Also with the type of surgery, if you had a mastectomy, you can see 89 versus 93%, about a 2 to 3% difference, but the hazard ratio here is 0.72. Okay. Now, here is the exploratory subgroup analysis. And in the exploratory subgroup, so these were not predefined, but here we see some interesting pattern as well. In the ERPR positive HER2 negative group, you can see 90% versus 94%, 91% versus 94%. And this hazard ratio is 0.41, and it's favoring regional nodal radiation. Okay. Now, I put this all together here in the predefined strata, the hazard ratios, and also in the exploratory analysis, some of the hazard ratios. Now, we have to be very cautious because the event rates are very low. This could all just be by random chance, and it's not a real finding. But it's still quite interesting. Now, there were no study-related deaths, and the toxicities were overall pretty low, as we would expect. We can do this treatment quite safely. So this is the approach that we have taken at Memorial Sloan Kettering after the publication of these data. And we initially were getting into a lot of discussion and arguments about how we should do this, but ultimately we kept it very, very simple. Okay, this is a very simple system. And you know, not everyone will agree with this, but this is kind of at least what we're doing right now. So for patients who are clinical T1 to 3, clinical N1, and achieve YPN0 after neoadjuvant chemo, if they are YPT0N0, meaning total pathological complete response, or if they're YPTIS, or even if they're YPT1, meaning that their tumor is less than 2 centimeters, irrespective of their subtype, we will not treat them with post-mastectomy radiation or RNI. However, if they have 2 centimeters or more of residual in the breast, we will treat them with RNI and PMRT. Anybody who's node positive after neoadjuvant chemo, including micrometastasis, we will treat. Okay. We, of course, won't treat anybody who's clinical T4. We won't omit radiation in anybody who's clinical T4. And we'll treat, of course, we would treat anybody who's clinical N2 or clinical N3. All of them require treatment. Now, I have heard, from many people, and I think this is valid, there are many people who are taking a subtype-specific approach to this, saying that they don't want to apply these data in the hormone receptor positive, HER2 negative group of patients. They want more follow-up data. And I don't think that's wrong. I think that's okay, because only 20% of patients on the study were in that subgroup. And And so I think that's valid. The reason that this system still works is that most of the hormone receptor positive, HER2 negative patients, they don't achieve a total pathological complete response. That does not happen in those patients typically. If it does happen, if they truly have a pathological complete response in the breast and in the nodes, then we believe that if the tumor is gone, it's gone. There's At that point, there's really no need for radiation. So we believe that pathological data, and that we believe that that applies across all the subgroups. So we don't think that in this for a true total pathological complete response, the subtype really matters. Now in the T1N0, I think that's a little debatable. We've taken the approach that many of these T1s, if there's just a little bit of tumor left, it's kind of a path CR in evolution, meaning if you gave it a little more time, it may have become a path CR. So that's our approach, but I recognize that there can be some uncertainty with this, and we can talk about that at the end. So that's B51. Why do we treat? So I said that we will continue to treat micrometastasis, and there are data here to show that there is a drop off when you have micrometastasis after neoadjuvant chemo. This is an analysis from the NCDB suggesting that. Another paper from I believe UNC that also shows that if you have micrometastasis, you're kind of in between having a YPN0 versus YPN1. So we think that the micrometastasis still needs to be treated. Dr. Sehrish, do you want to do questions now, or should we do the whole talk and then do any questions at the end?
Yes, I think we can take questions from the audience, or the audience can drop their question in the chat box, or I have a couple of questions.
Sure.
Yeah. Dr. Atif, can you go back to that slide, which you showed that how you're treating patients? Yes. My question is that if someone is YPN plus, the patient has only the microscopic deposit. The complete response has been shown in the breast tumor, and there is only a microscopic deposit in the node. And the surgery, complete surgery, axillary lymph node dissection has been done. Do we still need radiation?
Well, that's a great question. That's a tricky question. It's not a very common scenario because usually the nodal response precedes the breast response. But your question is, what if you have a complete response in the breast, only a micromet in the node, and patient also had an ALND? Now, I should have mentioned that, in our environment, we have migrated quite a bit from ALND to sentinel node biopsy. In the study, it was about 60-40. Sorry, let me just show you the sentinel node. So you can see here, 55-45 favoring sentinel node versus ALND. So yeah, I think that's a tricky question. There's not going to be an absolute right answer to that. In our system, we would treat them because of these data. So just to get more into these data, so these are patients who everyone had neoadjuvant chemo, and then this is their outcome plotted by how much disease they had left in the axilla. Okay, the blue line here is YPN0. The yellow line is YPN0, but I positive, so isolated tumor cells, or positive by IHC. This YPN1MI is this green line. You see that? And yeah. YPN1 is this orange line. So this green line it's separating from the YPN0. So we think that this data is real. There's some newer data that's coming out. I haven't seen it yet. There's an argument against this that this green line really behaves more like the blue line, but this is from 2019, so it's a little bit old. But we are still operating on this assumption that on these data, and this is showing you the same thing. It's a little bit harder to see, but this solid line is how much. So this is how much centimeters of disease left. So 0 is a solid line up here. 0 to 2 millimeters, so that's a micrometastasis. That is the dashed line, which is which is this one, I guess. Yeah, this is the dashed line. And then sorry, this is zero. This is the micromet one. 0.2 to 2 is the micromet. So that's this dashed line. But it kind of starts to separate from, from the sorry, this is the micromet. So yeah, it separates from the other one. It's different from the YPN0. You can see that they're clustering. And then if they have more than 2 centimeters of disease, it's actually quite bad. But this line is different from this line, and that's why we think that if you have micromets after neoadjuvant chemo, you do worse. And this is actually distant disease-free survival plotted on the y-axis. So this might be pretty important. So we still, for your patient, we would treat them, yes.
Sorry, you said you will treat the patient?
Yes, for your patient, we would treat them, yeah.
All right, okay. And yeah, there's a question in the chat box from Dr. Agha Mohammed Hamad Khan.
But just to go back to your question, it would have been preferred if that patient first had a sentinel node biopsy and that became known, the micromet. I wouldn't have sent them back for ALND. I would just have proceeded with radiation.
Actually, in our setup, Dr. Atif, patient present after the surgery, yes. So they come up with after the axillary dissection. So we need to take the decision whether to give them radiation or not when 16 lymph node has been involved. And yes, so sometimes it becomes really, really tricky what to do.
Yeah, but these data, based on the period of time when these people were treated, I'll change this slide to add the period of time. But most of these patients were getting ALND, so this finding is true in ALND patients. So, yeah.
Yeah. So we have a couple of questions in the chat box.
I can't see the chat box, so because I have the slide show up, but
you can't see the chat box?
No, I can't. No, I can't see the chat.
All right, I can read the question for you. So one of the question is from Dr. Sarah Sabha. She's a resident, and she's asking that does tumor biology not affect the decision of radiation therapy?
Not right now. I mean, it possibly will. Like I said, with more follow-up, we may learn that these late recurrences in the hormone receptor positive group become a problem in the arm where regional nodal radiation was not given. But right now, in patients who have an excellent response, look, here's the thing: if the tumor is gone, it's gone. And it may not matter what the underlying biology was, because remember, they're getting biologically directed chemotherapy, right? If they are HER2, for example, they're getting HER2 directed treatment. If they're triple negative, they're getting some triple negative breast cancer directed treatment. So it may not matter. Like if the tumor is gone after neoadjuvant chemo, the radiation may not matter by biology or by anything. I know that's yeah. So go ahead.
So, but Dr. Khan, you just showed us in the forest plot that the patients who had the ERPR positive disease and HER2 positive disease, they did well with the radiation.
No, what I showed you was that if you had ERPR positive HER2 negative disease, there's about a 3%, 3.5% difference here in this exploratory analysis. But if you look at these numbers, 7 out of 155, 17 out of 173. Both the denominator is very small here and the numerator is very small. And this finding, it could be real, but it could also, we have to acknowledge that it could be by chance. Look, I'm a radiation oncologist, so, I'm looking for a story here that suggests that our treatment is beneficial as well. But it's hard because the majority of these people had a path CR, 80% had a path CR in the breast. So they had no tumor cells in the breast or the nodes. And, if you're triple negative or if you're HER2 positive, there's really no benefit. I don't see a reason why we would treat those patients. Like especially if they had a path CR. And I think the only place where we have uncertainty and where I think you could make a case that you don't want to apply these data is in the ER positive, HER2 negative patients who don't achieve a path CR in the breast. That's the group where I think the question is still a little bit unanswered, and there's room for debate. I think in the HER2 positive group, if they have a path CR in the nodes but not a path CR in the breast, depending on how much disease they have left in the breast, that's why we say this, YPT2 or higher. This is a way of saying RCB, 2 or 3 in the breast, and that's where we think we should be treating them, even if whether they're triple negative, HER2, ER positive. If they have disease left in the breast, we should probably still be treating them. So that's kind of where we're at.
Right. So I think we have one more question, Bob, from Dr. Aga Mohammed Ahmad.
Do you mind reading it?
Yeah, I'm reading it. So he is asking that was the targeted lymph node dissection was allowed in the study?
That's a good question. That was not recorded in that way. Was it allowed? It was not allowed, or there was no comment on that type, the technique. All that was said about it was that a minimum of 3 nodes had to be looked at. And if you did a sentinel node, there was a minimum of
I think 2.
I believe it was 3. Yeah,
2?
I think it was 2.
That's
2 or
2.
3, I forgot. Yeah, I think it might have been 2. Yeah, actually might have been 2. Yeah. Now, whether you did TAD or something like that, the study did not specify that. It was agnostic to that. So there may have been some centers that were doing that, others were not doing it probably. So we don't have that.
All right, Dr. Khan. So I think we can move to the remaining presentation.
Okay. All right. Now let's switch to hypofractionation. Hypofractionation is a standard of care after lumpectomy. We know that from because of this work that was done in hypofractionation after breast conservation. But in the PMRT setting, this is more limited, especially after reconstruction. And in this environment, most women have reconstruction. So there's this open question of like, what will hypofractionation do to a reconstruction? And so this was data that we felt was an evidence gap. And I did a trial on this phase 2 study that was published in the JCO a while ago now, sort of demonstrating that we could safely do moderate hypofractionation after PMRT. At that time, there was not a whole lot of this that was being done. And from there, we took the idea of doing this in a bigger study to Alliance, which is one of the cooperative groups. And what we proposed to them was doing a randomized trial of conventional fractionation or moderate hypofractionation in mastectomy patients, all of whom have a reconstruction. And by doing that, we can use as our primary endpoint reconstruction complications happening with the use of the shorter course of radiation. We can also then look at other secondary endpoints like other toxicities, lymphedema, et cetera. So we powered the study for reconstruction complication rate at 24 months and assumed a background rate of 25%. And this was a non-inferiority design with 800 patients needed, approximately 800 patients needed. And so this is what the schema looks like. Everyone had mastectomy. Everyone had to have a reconstruction, or if they didn't have, they at least had to have the intention for reconstruction, even if it was going to be delayed. And the randomization was 50 gray and 25 fractions, or 42.56 and 16 fractions. And we did a lot of QA, both in B51. There was a lot of, my main job was to actually look at the plans and make sure the quality was good. We did the same thing here. We looked at every single plan to ensure that the quality was high, because if there's poor quality, then the results can be confounded by the poor quality. So again, 24-month reconstruction complication rate, 10% margin. These were the eligibility, and pretty similar to what you saw. You could be T3N0, but otherwise you had to be node positive, either clinically node positive at baseline before neoadjuvant, or pathologically node positive. Could not be T4 or N2 or N3. And the primary endpoint, which was reconstruction complications at 24 months, this was a composite of Baker 3-4 contracture or any reoperation or hospitalization that was considered to be non-routine. Okay, and then secondary endpoints of acute and late toxicity, local regional recurrence rate, and also to look at the reconstruction complications by the reconstruction method and the timing and type of reconstruction. So the study ran between 2018 and 2021, and it was reported at Astro, I guess 2 years ago now, right? Yeah, not this last time, but the time before that. And we had 900 patients who enrolled. The arms were pretty well balanced. And at the high level, what the study showed was we demonstrated non-inferiority in the intention to treat analysis. You can see that the rate of reconstruction complication at 24 months was pretty low. It was lower than what we were expecting, 14%, 12%, and there was no difference between the two arms. Now, a couple of things here that also came up was, so for example, here, when you look at autologous versus implant only, the autologous seems to be having a slightly lower chance of a reconstruction complication than implant only. But across all of these groups, there was no difference by treatment arm, whether it was short or long PMRT. And then in a multivariate model of reconstruction complications, conventional versus hypofractionation was not a risk factor for reconstruction complications. However, this autologous versus implant only, you can see the odds ratio was about 0.5, favoring autologous rather than implant or implant only. Now here is a slightly different look at this, which is looking at the results by what actually happened in these patients, because you can have an expander in, and you can have sometimes the intention is one thing, but what is actually delivered for that patient ends up being different. So this is what by the reconstruction that was actually performed, and you can see all of these are actually there wasn't any subgroup. This is exploratory, but there's no subgroup by type and timing that seemed to be significant for better result with conventional PMRT. So non-inferiority is demonstrated. I will say that if you look at the trend line here, it's sort of favoring conventional fractionation. You can see that there's sort of like, moving in the direction of hyperfractionation inferior, but these were all statistically not significant. And another thing that came up here is when you look at the timing or type of reconstruction, immediate seemed to do better than, so if you had immediate followed by a delayed implant, that was sort of like the worst finding here. So about 20% chance of having a reconstruction complication. Whereas the immediate, if you did immediate implant, you had a very low chance for so having a 2-staged operation seemed to be worse than having a 1-staged operation for the reconstruction. So this is also showing the same thing by what was actually received. And here's the other toxicities, just any type of acute or late toxicity. And you can see the rates were pretty low here, as you would expect. And the local regional recurrence risk was also very low, with both of the arms overlapping, no signal for inferiority in any arm. So it appears that hypofractionated, moderately hypofractionated PMRT and reconstruction is non-inferior to standard fractionation for most patients. So, and one secondary finding here is that implant only and two-stage reconstruction seem to have independently have higher risk of reconstruction, regardless of fractionation, compared to autologous and compared to a one-stage procedure of any kind. So these were two things that sort of came out of this study. Now, I want to switch. We have about 10 minutes left. Let me just spend 5 minutes on techniques, because I think this is important. When I did the QA analysis for both of these trials, there was a lot of mistakes that happened. For example, here's someone's contour for the supraclav volume. This is just on the scalene muscles. The actual contour should be here in this hypodense fat space right behind the sternocleidomastoid. That's where the nodes can be. And there was a lot of this kind of thing that we saw on the studies. Now, why is this important? Because we have a very thin benefit of PMRT RNI. And just like in all of radiation oncology, we have to do our best to cover the target volume, but we also have to try to spare normal tissues. And this is especially important when the benefit of your treatment is very low, but there's a big patient population, right? There's a lot of breast cancer. So if you're doing this wrong, it can actually end up affecting, quite a few patients. So you have to do this right. Also, if you do this wrong, whatever benefit you're producing with the radiation is so thin, you could turn it into a negative if you can lose, or you can lose the benefit, or you can turn it into a negative if you are not doing this correctly. Now, one of the things to understand is the patterns of failure. Where do nodal recurrences happen? And there's some pretty good data on this. There's some pretty good atlases mapping recurrences. There's one from our group. I'm not going to go into all of these data, but you can actually look at this. And the atlases that are out there, RTOG, Estro Atlas, they don't generally cover all of these failures, like especially occasionally you can have failures in the posterior neck or in the high axilla. I don't think you need to be treating all of these patients all the way back. If you're using a highly conformal technique like IMRT, you don't need to go into the posterior neck for every single patient, but for a very high-risk patient, you probably should. Here's another atlas, from a European group, the BORM atlas. They actually have a very nice appendix here. It's like a heat map of where these recurrences are happening. So I would encourage everyone to look at this as well. It's pretty nice. One thing that people do wrong a lot is they miscount the intercostal spaces. So it's good to understand the anatomy that the top three intercostal space, the third intercostal space ends at the top of the fourth rib. And you can count these ribs on your axial CT. Sometimes what becomes confusing for people is that the clavicle is also there. The clavicle is not a rib, so it shouldn't be counted, obviously should not be counted as a rib. And the first rib starts off above the clavicle and ends up below the clavicle. So that's the thing that gets confusing for people. I think that's where the miscounting happens. Sometimes you can count here in the sagittal, if that helps some people. But this is sort of what it should look like. Same thing with the axilla. Understanding this anatomy is good. So this is a sagittal section of the axilla. This muscle that's deep in the axilla, kind of the bed of the axilla, is the subscapularis muscle, and then you have the latissimus dorsi. You have the teres major and the latissimus dorsi. So this is sort of the deep surface of the bed of the axilla. Of course, you have the pec minor and major in front, and the nodes are in this fat space that are between these muscles. Generally, for most patients, for most low-risk patients, you don't need to include the dissected volume. If you're using that's not really a part of the target. It was not a part of the target in B51. If they've had an ALND, like Dr. Sehrish's case earlier, you don't need to go chasing that volume. And that may actually reduce some morbidity for the patient. Okay, and supraclav, like I said, that's this hypodense fat space in front of the scalene, anterior and middle scalene muscles, and behind the sternocleidomastoid. And you should keep this away from the medial structures. You do not want to expand your contour into the esophagus, especially on the left side, into the thyroid. All of this should be trimmed back within zero margin, essentially immediately here. Okay, we're not going to get into the technique, so we can stop there and we can open up the floor for questions.
Okay, so we have a question in chat box. Would you please elaborate on how the quality of RT was assured with the implant, and what are the important perspectives to consider? What was the type of implant for these patients?
Okay, yeah, I can see the chat box now. So the way that the quality of radiation was assured is that either before the treatment or within the first week of treatment, there was a rapid review of the plan by in B51, we had 4 doctors, of which I was one, and everyone was a breast radiation oncologist. In RT Charm, there was 3 people doing it, same thing. And we would get the data, we'd get the plan data, we'd look at it, look at the coverage, look at the contouring. And then we would score that, deviation, minor deviation, major deviation. And if necessary, we would tell the site to fix the plan. Now, with respect to the reconstruction, if there's an expander and implant there, we were treating everything. We were taking kind of the US approach. We were not trying to spare, the implant or anything like that. So all of the skin, like everything, and from between the skin and the pec muscles, everything, all of that is included in the chest wall. As far as the type of implant, this was left at the discretion of the treating site. There was no constraint on it. The only thing that was not allowed, there's a type of implant called there's air implants, air expanders rather than fluid, and we did not allow for that because of the heterogeneity that would happen at the tissue interface. Dr. Shaukat has a question. How does B51 impact surgical decisions? We have gone to a situation where pretty much everyone starts off with a sentinel node, and their pathology is then evaluated. And this is also true in the upfront setting. Then we decide which ones should go for radiation and which ones should go back for ALND. We try to avoid a situation where someone ends up with both ALND and radiation. That's something that should be avoided because they have unnecessary toxicity. For the most part, women just need either ALND or radiation. We should really try to avoid, for this intermediate risk type of patient, we should avoid both treatments as much as possible. So the results of B51 haven't really changed the surgical decision in that way. The trend, kind of the secular or meta trend, macro level trend has been moving, very strongly towards SLNB for everybody. Just looking at how would you protect the heart, lung, esophagus, your technique? Okay, we didn't get into the technique, but I think the main thing is whatever technique you use, there should be a good set of constraints for these organs, including the esophagus, because the esophagus needs to be protected because patients can get acute symptoms from that, esophagitis. There can also plausibly be other risk factors like other bad outcomes many years later, like I don't know, second malignancy. So you should really just put the radiation where it's needed, and those organs should be protected. A good rule is lung V20 of under 35%, ipsilateral lung V20 under 35%, if you can make it, or at the absolute top of that, acceptable would be under 40%, because sometimes the anatomy can be quite difficult. Heart mean dose is a commonly used constraint, preferably under 4 gray. That's usually achievable. And if you have to, my approach is if you have to cheat a little bit on some of the target volume, for example, with your heart block, you're better off just blocking the heart completely and missing some of the target volume for most of these patients, because as we've shown, the event rate is pretty low. I think things would be different if you have a very high risk patient. If you have somebody who has 10 out of 10 positive lymph nodes after neoadjuvant chemo, and sometimes that happens, unfortunately. That's the type of patient where you really don't want to cheat on internal mammary coverage, all of your nodal targets. And so that's where you have to use the best possible technique. Maybe it's IMRT or VMAT, whatever you have.
Thank you, Dr. Atif. Okay, so you can ask.
Okay, so Dr. Atif, I have a question. I'm Maria from Khan University. So my question is, looking at the NSABP-B51 trial, which published a follow-up of 5 years for the patients who were predominantly triple negative, and a fewer population of the patient in that trial was hormone receptor positive. So in our population, we do come across a lot of hormone receptor positive patients, and many of them are actually young patients. So as a radiation oncologist, omitting radiotherapy on the basis of a 5-year follow-up by a trial that had even less than 20% of the hormone receptor positive patients, it gets a little challenging in terms of taking the decision. One thing, and the other thing is that how to counsel our surgical colleagues in a MTT setting on the findings that we are inclined toward considering radiotherapy in such patients.
What I would say, I've already acknowledged that the hormone receptor positive HER2 negative group is still potentially an unknown, right? So what you're describing is the tension that we have because the data are not adequate still, even after the trial. And I think one approach that can be taken that might even be better than our approach, or at least can be considered, is that somebody who has a YPT0N0, total path CR, irrespective of subtype, even if it's hormone receptor positive or HER2 negative, I think it's very reasonable to apply these data and not treat them. I think because if the tumor is, like I said, if the tumor is gone, it's gone. And you're going to have a very hard time as a radiation oncologist arguing against that. Because at a cognitive and rational level, the medical oncologist surgeons, they're not going to agree with that. They're not going to let you give a potentially harmful treatment to a patient who has that kind of pathological response. Now, in the hormone receptor positive HER2 negative group, for any patient who has even a little bit of breast cancer, even if they have just 0.5 centimeters of disease or something like that, I think that's where you could potentially make the argument that, look, it didn't respond completely. And remember, most hormone receptor positive HER2 negative breast cancers, most of them will not have path.
Yeah,
they're going to have less than a path. Yeah. So you can say to your surgeons and your medical oncologists, look, and this type of, like, you can tell them, if this patient had a path CR, I would be happy to just watch them because I believe the data would apply. But here, because they did not have a path CR and these patients are underrepresented in the trial and we don't have enough follow-up, I don't feel comfortable yet applying these data. And that's true. Like, that's a good argument, but it's also true. And you can potentially treat that patient.
Do you take into account their age?
Yeah, that's a good, that's another challenge is what if you have a combination of multiple risk factors? Remember I showed you the hazard ratios for the different things. So what if you have a patient who had a mastectomy, not breast conservation, and they're young, and they are, maybe they had a sentinel node, and they had hormone receptor positive HER2 negative, right? So you're stacking multiple of those hazard ratios. Each of them individually p-value was not significant, but what if you have multiple of those now, right? So I think that's valid. I mean, yes, you can then say you do want to treat that person. But I think fundamentally, though, that if someone, let's say you have a HER2 positive breast cancer patient, and she has a path CR, breast and nodes, and she happens to be in her 40s, I wouldn't treat her because remember, your treatment has toxicity. We, as radiation oncologists, we always forget or we try to minimize the fact that our treatment has side effects. For a 40-year-old, the side effects are potentially worse, right? Because this young age argument, it's a double-edged argument. yes, we want to be aggressive and minimize the chance for their cancer coming back, but they're also more at risk for toxicity. They have, 40 years to be at risk for toxicity from your treatment as well. So you have to be careful in those younger women. It's a double-edged argument.
So
I think we do not have any more
we
questions.
do not have any more questions. So Dr. Nadeem Pervez is with us. So I would like to request him if you want to add something. Yes, he's here.
Actually, thank you very much, and Atif, for sparing your time to talk about this very important topic for our region. And thank you, Sehrish and Maria, for organizing that, and all the audience who's actually listening for all this. We have some challenges, and Dr. Atif, thank you for emphasizing on few very important points, that this study does not apply to patients who are clinically T4 or N2 or N3. We have seen in our region sometimes people use this data and apply to everyone. And also really like your summary of what your practice in your center, and I would request everybody else to have that slide to follow that principle, because if the biology of tumor is good, then tumor will have complete response, or good response. So we already know that, with this, that if this complete response, you can omit. If it is partial response or some response, then you can select those patients. So I think this is very important point what Dr. Atif have mentioned to all of us. So careful about using the study, the way it was performed and the way it revealed. So that's a very good, and more important point, actually, I would suggest Sehrish and Maria to think about target delineation, another talk or webinar, because if you look at that, we not only we draw that what Dr. Atif have shown, one with the muscle drawn. If you don't draw, then some other of your colleague will insist you to draw that. They think they are vessels, and I actually faced personally in here that I was told that my target is not correct because I'm not taking the muscle into my target. So, and then he mentioned about something very important. We see lymphedema to the patient who are dissected axilla should not be treated, because the risk of recurrence is so low and toxicity is so high that we should not. So these are our challenges, all covered very well in this talk, and I really thank you, Dr. Atif, for talking about this topic, and also to share the RT Charm study. I have one question before do the conclusion. Sorry about that. Was listening, all the audience was asking quite interesting question. In the RT Charm study, when you do PTV, you grow the PTV. CTV is target, your skin is also CTV, I assume, because they're mastectomy. Then
Yes.
how do you assess the DVHS? Do you use PTV eval? And if you do, then how much under the skin you go for PTV eval?
That's a great question. Yeah. Usually they do a 3 millimeter kind of, because you're right, the dose optimizer doesn't do very well at predicting the dose there. So I actually don't remember exactly how they did that but there is a PTV valve structure.
Right.
There.
I do remember, for the mastectomy patient, they were using 3 millimeter because this is the dose, the dose are not very well predicted. So up to 3 millimeters, that probably would have been used for this one maybe as well.
Yes, yeah. Also, because of that, a lot of the planning, there's bolus in the planning, which improves the like the prediction of the anyway. Yeah, so there's bolus was allowed. Chest wall boosts were not allowed on this study. The bolus was at the discretion of the treating doctors, and but chest wall boost, additional dose to the chest wall, was not allowed on the study. So,
but bolus was allowed.
Bolus was allowed, yeah, in RT
Okay.
Charm.
Good number of people, they use bolus as well.
I don't have that data. Probably, I would expect, there's a lot of bolus use in the mastectomy patients, yeah. But it was completely at the discretion of the treating center. Yeah.
Yes, okay. For the RT Charm study, because after the implant, I was facing some challenges for skin reaction when we use bolus anytime. But
Yeah. No, it's
It's
a good
interesting.
point.
Yeah.
No, Dr. Nadeem is bringing a very good point, which is there are some data to suggest that bolus is bad for the reconstruction. We didn't control for that in RT Charm, and probably the randomization would just balance that out. But on the clinical level, should we be using bolus for PMRT patients? I think the answer just has to do with the risk level of the patient. I think right now we are over bolusing probably. There are probably many patients that don't need bolus. Like most 1 to 3 positive, like low risk patients probably don't need bolus. But we, by habit, we're just doing a lot of bolusing and after mastectomy. So I think that's a good point, actually.
Okay, that's actually great, and thank you so much, because we heard from you, and then we can quote, your words as well to our colleagues, and will help us to make the decision together for our patients. So, excellent talk and very good organization, and thank you everyone for attending.
Of course, yeah, you're welcome, and anything for Pakistan. So, as you know, all right.
Yes.
Okay. All right.
It was really an honor for us to have you with us today for this insightful session. I would like to extend heartfelt gratitude on behalf of all the participants from Pakistan for your valuable time, for answering all our queries, and we look forward to benefit more from your expertise in the future. Thank you so much.
And we would
You're
like
welcome.
to thank you again for